why have I chose it as a bird's eye view? Evaluation of a child with chronic diarrhea, the bird's eye view. Now, you all know chronic diarrhea, if you look at the list of etiologies, it's a very long list. There's 100 of causes which can give rise to chronic diarrhea in children. So it's in a 60-minute session, it's very difficult to go through each and every cause detail. So we are going to have an overall view or overall idea of how are we going to deal with a child with chronic diarrhea. So it's not something commonly we see, but if we come across a patient, we face lots of difficulties in handling a patient with chronic diarrhea. So for trainees as well as my clinical colleagues, just to give an overall idea how to deal with a patient with chronic diarrhea, I'm going to speak today as a bird's eye view or overall view on how to handle a patient with chronic diarrhea. Right. So moving on. So before going into chronic diarrhea, it's important to define or understand what is diarrhea initially, right? So we all know there are two components when you are defining diarrhea. One is the frequency, other is the volume. But frequency varies with age, diet, and person. So it's defined, in fact, by increase in volume and water content of the stool. So if you combine both these two, the WHO says, the definition of WHO is that passage of loose or liquid stools more than 3 times a day or more frequently than is normal for that individual. So 3 times or more per day, which is inconsistent, it should be loose or liquid, and which should be abnormal for that particular individual or the particular child. So this is the definition given by the WHO when defining diarrhea. So let us speak about what is chronic diarrhea now, right? Now, speaking about chronic diarrhea, there are two terminologies which we need to understand. One is chronic diarrhea itself, and the other one is persistent diarrhea, right? So let us speak what are these two terms mean. So chronic diarrhea is a diarrhea which lasts for 4 or more weeks, where the stool volume is more than 10 grams per kg per day in a toddler or an infant, or more than 200 grams per day in older child. And this chronic diarrhea can be associated with malabsorption and growth faltering. So this is chronic diarrhea. Whereas there's another entity called persistent diarrhea. It's an acute diarrhea which is lasting beyond 14 days, but not going beyond 28 days or not going beyond the 4 weeks cutoff. So this is something between 14 days to 28 days. This is called persistent diarrhea. And the studies have shown that this persistent diarrhea is usually due to multiple sequential enteric infections. So it's due to the enteric infections per se and the mucosal injury caused by the etiological enteric infections. So infections itself is causing the persistent diarrhea plus the mucosal damage. In combination, it causes the persistent diarrhea. So these diarrheas usually last from 14 days up to 28 days. Okay, so this is called persistent diarrhea. And chronic diarrhea which goes beyond 4 weeks, which is associated with some sort of malabsorption or growth faltering. So we are going to speak, although our topic is chronic diarrhea today, we are also going to touch on persistent diarrhea as well. Right. So when you speak about the epidemiology, the chronic diarrhea has 2 distinct patterns. If you look at the epidemiological data in developing countries, chronic diarrhea is mainly due to intestinal infections. So it's mainly infections which is causing chronic diarrhea in developing countries. Whereas in developed countries, comparatively it's less, and the etiology will be depending on the age. So on the age only, based on the age, in developed countries, chronic diarrhea etiologies are different. So earlier I said that the persistent diarrhea is usually due to infections, whereas in developing countries, even the chronic diarrhea can be due to intestinal infections. And the prognosis depends on the etiology, ranging from self-limiting. It can be a benign sort of a toddler's diarrhea or a non-specific functional diarrhea, and can even cause severe intestinal failure in conditions like microvillus inclusion disease or tufting enteropathy. So those diseases can end up in intestinal failure. The prognosis can vary. So this is a spectrum of a disorder. If you look at chronic diarrhea, it's a spectrum where the outcome can vary based on the etiology. Right. If you look at the global burden or the global pattern, so in 2016, the latest data from Lancet what we got, in 2016, globally 500,000, that is 500,000 children had succumbed to diarrheal illnesses all over the world. And 1/3 of these deaths are due to chronic diarrhea. So nearly 150,000 deaths are due to chronic diarrhea all over the world. And in fact, diarrhea is the 5th leading cause of under 5 mortality. Now, if you look at this graph, from 1990, the number of deaths due to diarrheal illness has come down significantly. If you look at 2016, but still it's reasonably high. 500,000 deaths all over the world, it's reasonably high. And you can see the possible associated factors which are contributing to this sort of deaths. You can see in that graph. So it's mentioned in this graph somewhere here, right? So this is the global burden due to diarrheal illnesses or chronic diarrhea. Unfortunately, in Sri Lanka, we don't have enough data about incidence of diarrhea or chronic diarrhea. But again, if you think the deaths due to diarrheal illness in Sri Lanka is much, much less nowadays. For probably a decade or so, the number of deaths purely due to chronic diarrhea has come down, or diarrheal illness has come down significantly. Right. If you look at the diarrheal death by its infectious etiology, still the viruses are the predominant causes. So if you look at here, viruses are the predominant causes, followed by adenoviruses. Then even the cholera, shigella, which are predominantly in the African and sub-Saharan countries. So it is the predominant cause of death due to diarrheal illness. So now, to understand chronic diarrhea or the diarrheal illness, it's important for us to understand the normal physiology of fluid absorption in our gut, right? So if you take approximately, a child takes around 1.8 liters of oral fluid per day. So to that, saliva of 1.6 liters will get added. Another 1.6 gastric secretions, another bile 1 liter, pancreatic secretion 1 liter, and the intestinal secretions 2 liter. Altogether, roughly around 9 liters of fluid goes into the small intestine. Of this 9 liters, around 7 to 7.5 liters are absorbed by the small bowel. So remaining 1.5 to 2 liters will enter the colon. But again, colon also plays a significant role in absorption of fluid. Another majority of that fluid also will be absorbed. So which passes the colon and goes into the rectum is roughly around 150 to 200 ml of fluids. So if you have to get significant diarrhea, there should be a significant disturbance of these absorption functions. So even if the small intestine fails, the large intestine is doing a significant contribution of absorption. So that also has to fail. So overall, for you to get watery diarrhea or chronic diarrhea, there should be disturbance on this system, right? So we shall look at the factors regulating the fluid transport in the gut. So that is the fluid absorption and the fluid secretion. So there is active transport of ions of sodium, chloride, and bicarb across the enterocyte via the ATP-dependent membrane transport. That is one factor playing a role. Then the intact epithelial barrier function. This is the second factor, which does not allow the fluids which is absorbed into the enterocytes to leak into the lumen. Third is the normal motility of gut. So there should be sufficient motility for your fluids to be absorbed properly into the gut, right? So if you look at the first factor, so movement of sodium from the mucosa to the serosa drives fluid absorption. So when there is sodium movement from the gut lumen into the mucosa, there will be water movement as well. Whereas chloride movement from the mucosa into the gut lumen will cause fluid secretion. So when the fluid absorption is less or fluid secretion is more, there is going to be diarrhea. And the intact epithelial diarrhea function, it prevents, as I said, it prevents the back diffusion of electrolytes and water into the intestinal lumen. So it is binded to each other with several proteins very tightly. So it doesn't allow the fluids to get leaked into the lumen. Thirdly, the normal motility of the gut. So for your fluids to get absorbed properly into the enterocytes from the lumen, there should be adequate transit time. If the transit time is very rapid or very slow transit, that will result in poor absorption. So if you look at these diagrams, now I will explain the first diagram. If you look at, so this is the enterocyte. So here, from the enterocyte into the tissue, sodium is going out. So there will be sort of low sodium here. So from the lumen, sodium will go in. With the sodium, chloride also will go in. So water will be following it. So water enters the cell via osmosis. This is what the water absorption mechanism. The water secretion mechanism from the intestine is showed here. Now you see sodium chloride channel is there. When the chloride enters into the enterocyte, it is excreted or secreted out via the CFTR channel. With that, water will leak out. So if there's a balance disturbed where less water is absorbed or more water is secreted, you are going to get diarrhea. So this same mechanism we are going to apply into the common two diarrheas, osmotic diarrhea and secretory diarrhea, and see what happens exactly. Now the osmotic diarrhea, what you see is in the colon, you have a lot of osmotically active substances. So because of these substances are there, lot of water is leaked out. So for example, now one of the good examples for osmotic diarrhea is lactose intolerance. Now you have lactose in the gut lumen. So that is the osmotically active substance. So water is leaked from the intestinal cells into the lumen. So there is a lot of water coming in. Similarly, bacteria will act on the lactose. It will ferment it. So there will be production of gases. Similarly, more osmotically active molecules. So again, there will be water leakage. So this is the mechanism of osmotic diarrhea. Whereas looking into secretory diarrhea, what happens is, so toxins, viruses, medications will activate these chloride channels. So there will be lot of chloride leaking out into the lumen. So water will be also leaking with that. So this is the mechanism for secretory diarrhea. So if we go back to the previous diagram, sorry. So water leakage is happening through this mechanism, right? So this is the main mechanism which is playing the role in the osmotic or the secretory diarrhea. So I hope you would have understood this diagram. So if you look at clearly, it exactly shows how the osmotic diarrhea happens and how the secretory diarrhea happens. So as I said earlier, etiology for chronic diarrhea, there's a big number of causes. There is a big list, more than 100 of odd etiological agents or conditions are being found for chronic diarrhea. But we can classify them into various categories: infectious, inflammatory, carbohydrate malabsorption, protein losing enteropathy, liver and bile acid disorders, pancreatic insufficiency, motility disorders, congenital diarrheal disorders, short bowel syndrome, and functional diarrhea. So these are the main categories of etiological groups of chronic diarrhea. So if you look one by one, in regard to infectious causes of chronic diarrhea, again the prevalent infections are different in geographical ranges. So in developed countries, Clostridium difficile is one of the commonest organism, followed by lots of viruses, norovirus, astrovirus, and rotavirus, etc. So these are the predominant prevalent infections which is causing chronic diarrhea in the developed countries. If you look at the developing countries, E. coli, Shigella are the more predominant or more leading causes of chronic diarrhea, whereas rest of the rotavirus and the parasites will follow those bacterial and viral causes. So based on the geographical pattern, the etiological agents differ, especially the infection causes differ. Then coming into the next group of categories, inflammatory. So inflammatory causes of chronic diarrhea, the common causes are like celiac disease, the food allergic causes, inflammatory bowel disease, autoimmune enteropathy. And if you look at carbohydrate malabsorption, which is causing chronic diarrhea, the common causes are congenital lactase deficiency, fructose malabsorption, and hereditary fructose intolerance. There are various other conditions as well, but I have just picked up few common ones. And protein-losing enteropathy causing chronic diarrhea causes are intestinal lymphangiectasia, infections, and inflammatory conditions. Then looking at the liver and bile acid disorders which causes chronic diarrhea, the commonest conditions are primary bile acid malabsorption, the PFIC syndrome, that is the progressive familial intrahepatic cholestasis, which is earlier called as bile disease, Wallman disease, and all the other biliary and chronic liver diseases. And causes for pancreatic insufficiency which cause the chronic diarrhea are common causes are Schwarzman syndrome, autoimmune polyendocrinopathy type 1, and cystic fibrosis. And there are some other motility disorders which can give rise to chronic diarrhea as well. The commonest ones are Hirschsprung disease, which can cause initial early constipation, then enterocolitis, as well as protein-losing enteropathy. So these are all the ways it gives rise to chronic diarrhea. Then chronic intestinal pseudo-obstruction is another motility disorder which can give rise to chronic diarrhea. Then in the list, there was, if we go back, there was one group called as congenital diarrheal disorders. This is a big list of conditions which usually present in the first month of age. So those are the conditions which are also called as congenital enteropathies earlier. Now it is been classified or named as congenital diarrheal disorders. So these are all conditions which would give rise to neonatal diarrhea and would present usually within the first month of life. So these congenital diarrheal disorders always have a molecular defect, and the genes have been detected, and based on the molecular defect, they have been classified into various groups. So the common conditions which we come across, you can see in this list, the congenital lactase deficiencies, the congenital sucrose isomaltase, galactose malabsorption, the acrodermatitis enteropathica, congenital chloride diarrhea, so etc., etc. So these all congenital diarrheal disorders have been classified based on their molecular defect. And if you look at this list, almost all of them are autosomal recessive conditions, except for one. If the trainees, if you can guess, that is IPEX syndrome. So it's X-linked. All the others, almost all the others are autosomal recessive in inheritance, and almost all of them present within the first month of the age. And most of them are very, very severe presentation, and they are on the one end of the spectrum which I mentioned earlier, and they can give severe protracted diarrhea, and which can end up in intestinal failure. And one of the another interesting group of disorder which give rise to chronic diarrhea is the functional diarrhea and irritable bowel syndrome D. I hope you understand what do I mean by irritable bowel syndrome D. It is irritable bowel syndrome with diarrhea. So there is another entity called irritable bowel syndrome without diarrhea. This is with diarrhea. So now the studies have shown this is one of the leading causes of chronic diarrhea in children. So most of them are otherwise clinically very well. They do not have any organic pathology, but would have persistent diarrhea. So this functional diarrhea is the one earlier been called as toddler's diarrhea, non-specific diarrhea, etc., etc. So those diarrheas have been now classified as functional diarrhea, and it is being included with the irritable bowel syndrome. So these children, they pass unformed stools. Some might pass undigested food, and most of the time it's painless stools. And if you go to the history detail, it's most of the time associated with overfeeding. Sometimes there will be excessive fruit juice intake, excessive carbohydrate consumption, and excessive sorbitol intake. If you look at them, they will have, most of these children will be drinking lots of fruit juices. So these are the associated factors. But the studies or the papers say that most of the functional diarrhea and irritable bowel syndrome are in a way related with the intestinal motility disorders. So intestinal motility disorders are one of the key factors in the pathogenesis of development of functional diarrhea. Right. So after discussing about that etiological agents or causative agents for chronic diarrhea, let us now go into the evaluation of the patient. So in the evaluation, nothing can replace the history. So a detailed, proper history has a paramount importance in managing your patient with chronic diarrhea. So it's very, very important to get a very good history. And most of the time with the history, you can narrow down your diagnosis, right? So based on the age and the time of the onset of the diarrhea is from birth or early infancy, as I mentioned earlier, congenital diarrheal disorders are one of the commonest groups which can present at this age. So you have to think about that. In addition to that, necrotizing enterocolitis or any other structural or anatomical abnormalities of the gut also can present very, very early in the infancy. But early presentation can be also seen in infections as well as certain food allergies or food intolerances. So you have to consider about these two entities as well. Older children and adolescents, inflammatory bowel disease is one of the leading causes which can present as chronic diarrhea. So in the adolescent age group, we have to think of IBD rather than the CDD, right? Whereas celiac and functional diarrhea can be present at any age and should be considered at all ages. Next, based on the duration, if the diarrhea is very abrupt onset in a previously well child who did not have any significant GI problems, abrupt onset of diarrhea, which is lasting less than 4 weeks initially, you have to think of an infectious origin. This is the protracted or persistent diarrhea group, right? Chronic infectious diarrhea in immunocompetent group, you have to think of giardiasis, amoebiasis based on your geographical area. If the chronic infectious diarrhea is seen in an immunocompromised child, you have to think of these following agents which I have mentioned: Yersinia, C. difficile, giardiasis, Cryptosporidium, rotavirus, CMV. So these are all common organisms which can cause chronic diarrhea in immunocompromised children. And acute onset diarrhea with a protracted course. So in a previously well child who developed acute diarrhea, but this diarrhea is going on for 4 more weeks now. We have to think of post-enteritis diarrhea, which is one of the commonest conditions we come across in our day-to-day clinical practice. And secondary lactase deficiency, again, it is somewhat related to the post-enteritis diarrhea, where you will have the damage of the brush border and the lactase enzyme is going to be deficient transiently. And small intestinal bacterial overgrowth, as well as this can be the first presentation of a onset of toddler's diarrhea, because previously well child at one point can start developing toddler's diarrhea. So toddler's diarrhea is mainly due to, as I mentioned earlier, it's due to the sorbitol containing or carbonated drink containing foods, which can cause the protracted or persistent diarrhea. So birth history and family history is also important in evaluating a patient. So presence of consanguinity, polyhydramnios, and reduced fetal movements all suggest to a congenital diarrheal disorder. So, as I said, most of the or almost all the congenital diarrheal disorders are autosomal recessive in inheritance. So, you have to look about or you have to think about consanguinity. And especially conditions like congenital chloride diarrhea, congenital sodium diarrhea, which can have polyhydramnios in the antenatal history. In the family history, congenital diarrheal disorders are one of the important things you have to think. So if there's a family history or another family member being affected, so you have to think of the congenital diarrheal disorder because again, it's a genetic familial condition. Always it's important to get a detailed diet history. You have to have a 24-hour dietary protocol as well as you have to get the relevant information in regard to the diet. If it is an infant who is coming with chronic diarrhea, you have to ask about the type of feeding. What is the relationship of the diarrhea with feeding? And was the complementary feeding is already started? And what types of solids are being given? And what types of liquids are being given as well? In an older children or in an older child, consumption of fruits, fruit juices, water intake, all these are important. And always ask whether these diarrheal episodes are related to introduction of a specific food or giving a particular food causes or worsens the diarrhea. So these are the diseases like celiac disease, cow's milk protein allergy, food protein induced enterocolitis. All these are conditions which can be associated with a specific food. And drugs like magnesium, MMF, and laxative abuse, these all can give rise to chronic diarrhea. And previous history of bowel surgery, which can manifest as short gut syndrome, and exposure to radiation, which can give rise to colitis. These are all conditions which you need to identify in your history. Going into the examination of a patient with chronic diarrhea. So, as always, it's important to get the anthropometric parameters, the weight, height, the body composition, especially the skin fold thickness if you have the facility. So the anthropometric parameters, the weight, height, and the drop in centiles will tell exactly how severe is the illness, what is the chronicity, and what is the significance of the diarrhea, right? In addition to that, the dysmorphic features. So in pediatrics, we always think about dysmorphism when seeing a child with any particular condition. But in relation to chronic diarrhea, the significance of dysmorphism is, as you all know, the phenotypic diarrhea. The phenotypic diarrhea is where you will have a facial features with broad forehead and the other ear changes as well, right? Child being febrile or prolonged febrile illness would say this is a possible infectious origin, and child being ill will say the significance or the severity of the disease. And it's important to check the hydration status, look for malnutrition features, and look for specific vitamin deficiency features, right? So specific, and especially whether you can categorize whether it's a fat soluble vitamin deficiency or a water soluble vitamin deficiency, and that will give us some idea about your etiology. And a child with chronic diarrhea having edema, protein losing enteropathy is high on your list. Having digital clubbing will say celiac disease is one of the likely causes. Having perianal or circumoral rashes, acrodermatitis enteropathica is one of the important differential diagnoses you have to think of. And having abnormal hair. So Menkes disease and phenotypic diarrhea. So Menkes disease, you can have very sparse hair. Phenotypic diarrhea, which I mentioned earlier, the hair change is called as trichorexis nodosa. So going into the examination further, presence of dermatitis would say this is a possible food allergy related diarrhea. Having joint involvements, arthritis will suggest inflammatory bowel disease. Again, having different types of rashes, having oral ulcers, again will suggest inflammatory bowel disease. If you see any skeletal abnormalities in your child with chronic diarrhea, you think of Schwarzman syndrome, so which is associated with pancreatic insufficiency and some other full blood count changes. And if your patient has significant perianal excoriation, gaseous distension of the abdomen, you have to think of carbohydrate malabsorption. So your general examination itself will give lots of valuable clues which would guide towards your diagnosis. Then it's important to look at the stool. So macroscopically as well as microscopically. So as clinicians, it's important for us to look at the stool, whatever the history would be from the parent. It's our duty to look at the stools and come to some sort of a conclusion. So it's very, very vital to have a macroscopic examination, and this will give a very good clue in order to narrow down your diagnosis. So classifying the stool based on your macroscopic examination initially as watery, fatty or bloody is very, very important. So that will help to go further on your evaluation. So you can, by looking at the stool, you can classify it as watery, fatty or bloody. So again, in addition to that, doing stool microscopy, you can confirm whether it is watery, whether it is inflammatory, bloody or fatty. So if there is no white cells or red cells in the stool in a child with chronic diarrhea, you can narrow down it as watery diarrhea. Presence of both white cells and red cells in your stool microscopy will say this is a possible inflammatory or a bloody diarrhea. Whereas no white cells or red cells, but you can see lots of fat globules, that would suggest it's a fat diarrhea. But sometimes there will be overlapping of these conditions where you can have one or two of these two entities together, right? So there are clinical situations like that. So after narrowing down into 3 groups of your diarrhea patients based on the stool macroscopic examination and stool microscopy, you can go further, right? So initially, if we take the water diarrhea group, the water diarrhea can be due to osmotic or secretory. The osmotic diarrhea, as I said earlier, is due to unabsorbed solutes or nutrients. And the important clue here is the osmotic diarrhea would resolve with fasting, or if you remove the particular offending agent or the particular sugar which is the culprit, that will cause the diarrhea to subside. And these osmotic diarrheas are characterized by explosive frothy stools, which can give rise to bloating, flatulence, and perianal rash. And important mechanisms which give rise to the osmotic diarrhea is the intestinal damage due to enteric infections, reduced absorptive area, in example is celiac disease, defective enzyme deficiency, reduced intestinal transit time, and nutrient overload. All these factors are the mechanisms which would give rise to osmotic diarrhea. So, as I said earlier, watery diarrhea can be due to osmotic, can be due to secretory. So, secretory diarrhea, as I said earlier in that diagram, it is the net secretion of chloride bicarbonate or net inhibition of sodium absorption. So, either sodium is not absorbed properly, therefore water is not going into the enterocyte, or chloride and bicarb is secreted more, which causes more water loss. So, this can be caused by exogenous secretagogues, endogenous secretagogues, absence of ion transporter, or loss of intestinal surface area. So I have given few examples for each of these mechanisms giving rise to secretory diarrhea with few examples. So you can go through. In the next group, so after the water diarrhea group, bloody or inflammatory diarrhea. So this diarrhea is characterized by presence of blood and mucus in stools. GI infections are the most common causes for bloody diarrhea. So once infections are excluded, you have to think of other causes based on the age. Now, bloody diarrhea, most common cause is GI infections, but if you have excluded that, then you have to think of the other causes. The commonest causes of bloody diarrhea other than infections are inflammatory bowel disease, cow's milk protein allergy, autoimmune enteropathy, primary immunodeficiency, and necrotizing enterocolitis. Next, going into the fatty diarrhea group. So we have spoken about watery diarrhea, bloody diarrhea, now fatty diarrhea. So these stools are very oily, foul-smelling, bulky, and very difficult to flush. This is one of the histories. Mothers would come and say it's very difficult to wash the nappy, or it's very difficult to flush the commode after the child passes stools. So fatty diarrhea can be due to two main mechanisms. So it is either due to maldigestion or malabsorption. So your triglycerides might not be broken appropriately for it to be absorbed. So that is maldigestion. So here the stools are fatty but not loose. They are not watery. Whereas malabsorption, it is due to improper absorption through the mucosa. So here the stools are fatty as well as very watery. It's voluminous, right? So this will give some idea based on the stool. Even though if it's fatty, if it is not loose, you can think of maldigestion. If it is fatty and very watery, it is malabsorption. So once we have looked at the stool, narrowed down our diagnosis, we have done a stool full report initially, especially to look at the white cells, red cells, fat globules. You can investigate further. So in the stool microscopy itself, you can look at reducing substances, ovoparasites, and it's important to a stool culture. If you have the facility, stool cultures are one of the initial step of investigation you have to do in a child with chronic diarrhea. Then in addition to that, stool electrolytes and iron gap. Unfortunately, we don't have this facility of doing stool electrolytes, but for trainees, it's important to know this investigation. So that's why I have included. And stool calprotectin, right? So a few words about stool calprotectin. So stool calprotectin is a thing which you will see in the stools when there is inflammation. So it's elevated. This particular substance is elevated when there is inflammation. But only the significant thing what you need to understand is even in simple acute gastroenteritis, calprotectin can be elevated. But it will be elevated by hundreds. But if it is inflammatory bowel disease, celiac disease, or some other inflammation, it will increase very much beyond 500 and sometimes 1000. In Sri Lanka, most of the now government sector, we don't have stool calprotectin. Most of the private labs, they do the calprotectin levels. What they give us is the positive or negative report. They don't give us the levels. So that is sort of a drawback, because positive does not mean anything for us. Negative, of course, will give some idea that this is not inflammatory diarrhea, but positive does not mean anything, because even in an acute gastroenteritis or infectious diarrhea, you can have elevated calprotectin, which will be positive. But I think probably one lab gives the calprotectin levels, one of the private labs. So this is one of the things I think we have to develop in future. So I spoke about stool electrolytes and iron gap. So usually calculation of stool osmolar gap is important to differentiate whether it's osmotic diarrhea or secretory diarrhea. So normal stool osmolality is considered as 290, and minusing it from stool electrolytes into 2, if the gap is above 100, that means other than the sodium and potassium in the stool, there's another substance which gives the stool osmolality. So that would be the non-absorbed osmotically active solutes. So that suggests if your stool osmolar gap is above 100, that suggests you are dealing with a patient who is having osmotic diarrhea. If the gap is less than 50, that means most of the stool osmolality is given by or contributed by the stool sodium and stool potassium. So that is the secretory diarrhea, where lots of sodium and potassium will be lost into the lumen that will go into the stools. So this differentiation is important in academic aspect as well as in your future investigations. Then further going into the investigation, full blood count can give lots of clues. Presence of lymphopenia in a child with chronic diarrhea. Lymphangiectasis is something you have to think of. Having neutropenia, you have to think of Schwarzman syndrome. Eosinophilia will give a clue for cow's milk protein allergy. Presence of anemia. Now, in all chronic diarrheal illnesses, you might have some degree of anemia, but significant anemia can be seen. One of the chronic illnesses. And in the blood picture, presence of acanthocytosis will suggest A beta lipoproteinemia. In addition to that, your routine investigations like electrolytes, lipid profile, serum albumin, inflammatory markers are also very important. And blood gas analysis is again an important investigation because almost all your chronic diarrheas are going to give rise to metabolic acidosis. So especially if you look at the congenital diarrheal disorders, all the congenital diarrheal disorders would give rise to metabolic acidosis. Only one condition is going to give rise to metabolic alkalosis. That is your congenital chloride diarrhea. So that is an important clue. So all trainees should think, especially in regard to academic aspect. So remember that congenital chloride diarrhea is the only congenital diarrhea which can give rise to metabolic alkalosis. And it's also important to think of immunodeficiency. So if you have sufficient information or if you're suspecting, you have to do HIV screening and other immunodeficiency as per the history. Then the specific investigations. Now, unfortunately in Sri Lanka, most of these investigations we are unable to do. Some of them we can do, but it's important to know what investigations for specific malabsorptions. So for carbohydrate malabsorption, of course, you can do the stool pH. So presence of acidic stools and presence of reducing substance would say carbohydrate malabsorption. And again, acidic stool means normally in adult or in bigger children, your stools pH is going to range between 5.5 to 6.5. In infants, your stool pH is going to be somewhere between 4.5 to 5.5. So when interpreting a stool pH, you have to consider about the age as well. So breath hydrogen test is another good test for carbohydrate malabsorption. Then the small bowel mucosal biopsies, where you can take mucosal biopsy and using immunostaining, you can check the deficient enzyme. Again, unfortunately, we don't have this investigation in our country. So in regard to fat malabsorption, it's a very cumbersome investigation to diagnose fatal malabsorption, but there are very, very simple ways. So presence of fat globules in the stools, that is one of the things suggestive of fat malabsorption. And the indirect way of checking fat malabsorption is checking the levels of fat soluble vitamins, right? So if you have the facility to check the vitamin levels of particular fat soluble vitamin, that will give a good idea. Then checking the prothrombin time. So you know prothrombin time is dependent on the vitamin K. So if there is vitamin K deficiency, that will suggest fat malabsorption. So it's an indirect way of, so prothrombin time is indirect way of checking fat malabsorption. Then in regard to protein malabsorption, so when a child comes with chronic diarrhea, and if you are suspecting protein malabsorption, you would do a serum protein. And if you see hypoproteinemia in your child, your reflex should be to check urine protein excretion. Why? Although you are suspecting you are dealing with a child with chronic diarrhea and you are suspecting protein malabsorption, in children, one of the commonest ways of losing protein is your kidneys. So without excluding urine protein excretion, you cannot go ahead. So you have to at least do a UFR or 24-hour urine protein excretion and exclude there is no protein loss in the kidneys. Then only you have to evaluate further for protein malabsorption. So all trainees and clinicians, what we need to remember is when you see a child with chronic diarrhea having hypoalbuminemia, it's very, very important to urine protein excretion. Then stool alpha-1 antitrypsin level is another test for protein malabsorption where it's going to be elevated in the stools. Then there are further testing. So for pancreatic function, again, as I said earlier, like urine protein, sweat chloride test is one of the important tests for pancreatic function, because it is the most common cause of pancreatic insufficiency. The most common cause of pancreatic insufficiency in children is cystic fibrosis. So sweat chloride test is the test you have to do if you're suspecting pancreatic insufficiency. Then fecal elastase 1 level, serum trypsinogen levels. These are all can be done in sophisticated centers. And direct analysis of the duodenal aspirate, which is considered as a gold standard. And clinically, if you are suspecting celiac disease, IgA levels and tissue transglutaminase levels you should do. And if you are suspecting inflammatory disorder, as I said earlier, fecal leukocytes in the blood and fecal calprotectin levels. Then going into imaging, ultrasound scan abdomen is an important investigation, and sometimes X-ray abdomen contrast studies to look for congenital abnormalities or intestinal obstructions. And further invasive investigations, endoscopy, intestinal histology, and electron microscopy. Again, these studies can give some information about the underlying diagnosis. Again, if the facilities are limited, not freely available, so based on the facilities available, these are the advanced tests you have to do. So whatever we have discussed up to now, this is a rough algorithm of approach to a patient with watery diarrhea. So if you have a patient with watery diarrhea, you have to exclude protein losing enteropathy by doing this assessment, which I have already discussed. And based on the information we have earlier, based on the stool osmotic gap, with the results with fasting, you can classify it as osmotic diarrhea or secretory diarrhea. And if it is osmotic diarrhea, whether this is a congenital condition or whether it's developing in an older child, based on these tests, you can narrow down your diagnosis. So I'm not going to discuss this detailedly. All the tests and the evaluation which we have discussed earlier, we have put into this algorithm. So I'm sure the organizers will be forwarding these slides to you guys, so you can go through. And again, secretory diarrhea also based on the age group, based on the clinical presentation, based on the other investigations, you can narrow down into specific diagnosis. So this is the algorithm for watery diarrhea patients. So if you have a child with chronic diarrhea where you are suspecting inflammatory diarrhea, so this is the algorithm. So if you have inflammatory diarrhea, you have to first rule out infection, and based on the age of onset and based on the rest of the parameters and rest of the information in the history, you can narrow down into further. In approach to fatty diarrhea, again, if you have a child with fatty diarrhea, you have to exclude protein losing enteropathy. Then presence of fat globules or presence of fat acid crystals will suggest or narrow down your diagnosis, and you can further narrow down based on this algorithm. Again, I'm not going to go detail into that. Now let us speak about a few words about management. Again, management is quite complicated and it depends on the specific etiology, right? But for any condition which is causing chronic diarrhea, nutrition rehabilitation is very, very important. So if you come across a patient with moderate to severe malnutrition, you have to increase your caloric intake very, very slowly, because drastical increment in caloric intake can give rise to refeeding syndrome, which can be very detrimental and can kill the patient. So we have to be very, very specific on how we are going to slowly increase the caloric intake. And once you have reached the normal caloric uptake of that patient, you can go up further. So it is suggested that you can progressively increase up to 50% more than the recommended dietary allowance. And any child with chronic diarrhea, you have to start on lactose-free diet. So this is the WHO recommendation. So WHO says that any child with chronic diarrhea initially, because of the damage to the brush border and because of the secondary lactase deficiency, you have to start with lactose-free diet initially. And introduction of semi-elemental, elemental diets. These are the pre-digested or pre-prepared foods which in the elemental form, amino acids form. So this will easily absorbed into the gut in a child with chronic diarrhea who has damaged mucosa. So semi-elemental, elemental diet is a way of giving nutritional rehabilitation. So if the child feels difficulty in feeding, you can consider nasogastric or gastrostomy feeding. And if your oral nutrition fails, think of parenteral nutrition if the facilities are available. Next, about the diet modification. So in osmotic diarrhea, you have to avoid the relevant sugar based on the deficient enzyme. So if you are suspecting glucose galactose malabsorption, you have to avoid or you have to reduce the glucose galactose. So especially the milk products, milk containing products will have glucose galactose. Same with lactose free diet. In lactase deficiency, you have to give lactose free diet. And if you are suspecting sucrose isomaltose deficiency, you have to have low sucrose diet. Now, especially the table sugar, cane sugar has mostly sucrose. So you have to avoid that. But you can try honey and certain other vegetables. There are certain other fruits specific now. Fruits like apple, banana will have more sucrose. But fruits like cherries, berries will have more less sucrose. So you can consider those sugar containing foods. And if you're suspecting cow's milk protein allergy, maternal dietary exclusion of dairy. So mother should avoid having dairy food, so which can improve the condition if the mother is breastfeeding. And extensively hydrolyzed formula. So there are various extensively hydrolyzed formula, amino acid formulas. I'm not going to speak out the brand names. So, but there are products in the market available which can be considered. And if you're suspecting lymphangiectasia or steatorrhea or fatty stools, formula with medium chain triglycerides are again indicated. So this again, there are few brands, so you can check in the market. If you are suspecting celiac disease, the diet modification should include gluten-free diet. So there should be strict gluten-free. And if you are suspecting functional diarrhea, now in the algorithm, we saw classifying your diarrhea into various groups, but if you don't see any significant abnormalities in your examination, if you don't see significant abnormalities in your investigations, and if the child is growing well despite of having diarrhea, you have to think of functional diarrhea. For functional diarrhea, again, the pediatric gastroenterologist recommend 4F principle in the diet. So the 4F is reduction of fructose, reduction of fluids, increased fat, and increased fiber. So this sort of a diet is what they recommended for functional diarrhea. Then further into the management, so you have to supplement your patients with micronutrients. So micronutrient deficiency is something will have lots of impact in your physiological metabolism. So you have to supplement. Vitamin supplementation is important. Again, based whether it's a water soluble supplementation, water soluble vitamin deficiency you have, or fat soluble vitamin deficiency. And zinc supplementation is very, very vital. Again, there are lots of evidence, lots of research articles coming up in regard to importance of zinc in chronic diarrhea. So it prevents further diarrheal illness, it treats the diarrheal illness, it improves the iron absorption, it restores the epithelial proliferation, and also it plays a significant role in stimulation of the immune system. So zinc is very important. So not only in the acute diarrhea as well as in the chronic diarrhea. So when you are going into the drug therapy, so again, for specific conditions, specific drugs have been used. So antimicrobials for infection. So you can use broad spectrum cephalosporins. Certain conditions you can use ciprofloxacin. So based on the etiological agent, based on your blood stool cultures, you can treat with antibiotics. And rifaximin is a specific group of antibiotic which is used for small intestinal bacterial overgrowth. So bacterial overgrowth should be treated by rifaximin. And if you are suspecting autoimmune enteropathy or inflammatory bowel disease, you have to start on immunomodulators. I'm not going to speak about immunomodulators here because It's a vast separate topic, the inflammatory bowel disease. And pancreatic enzyme supplements for pancreatic insufficiency. In fact, we give pancreatin for children with cystic fibrosis, so which is available in our country. So that can be used for pancreatic insufficiencies as well. Then bile acid sequestrants, again cholestyramines, which is available for bile acid diarrhea. And octreotide or somatostatin analogs in lymphangiectasia and VIPomas, the tumors, neuroendocrine tumors. And in regard to probiotics, again, there's lots of dilemma, lots of discussion. So what they say in regard to chronic diarrhea, so if the chronic diarrhea is caused by C. diff or Clostridium difficile, probiotics has a place. But now you would have come across, it is commonly used in irritable bowel syndrome as well, but there is no evidence to suggest that it helps in chronic diarrhea related to irritable bowel syndrome. So that is the current evidence, but it might change. So I have given the references as well. So this is the latest evidence what we have in regard to probiotics in chronic diarrhea. So if you don't have a specific diagnosis, or if you don't have a specific treatment for the diagnosis, then there are certain agents which can use empirically. So loperamide, which commonly not used in children for diarrhea, but can be used in short gut syndrome. And this anti-secretory agent, the rasicodotril, it's effective in acute diarrhea, which is going on for some time. And studies have shown, again, based on the references I have given, there is a place for tricyclic antidepressants in irritable bowel syndrome. So there are lots of new evidence coming, new developments happening. So currently for intestinal failure in Western countries, intestinal transplantation has come as a rescue therapy. So in Australia, UK, in certain centers, it is been done. So intestinal transplantation is the way forward, or is one of the treatment modalities in this severe, especially the congenital diarrheal illnesses or severe untreatable diarrheal illness. Intestinal transplantation is one of the modalities. And now for etiology, PCR-based testing is being introduced or being tried. So that is one of the new things coming up, and there will be lots of progression in this. And as you all know, whole exome and genome sequencing. Again, this is one of the very promising diagnostic modalities coming up. Even in Sri Lanka now we are doing. So now the most of the conditions I explained earlier, I was telling you about the normal routine investigation what to do. But if you do the genome sequencing, it will give you the exact diagnosis. So if you are suspecting, we'll say Schwarzman syndrome. So doing genome sequencing in a blood sample, and even certain centers they are doing on saliva sample. So genome sequencing will give you the exact diagnosis rather than going through all those steps and invasive other procedures. And there are lots of new papers coming on gut microbiome. So gut microbiome is a developing field. So there are lots of new evidence coming, and there will be lots of new information in the near future. So these are the new developments in regarding to chronic diarrhea currently. So to summarize, so by this end of this 60 minutes, you all would have realized that evaluation of chronic diarrhea is very, very challenging. So evaluation of chronic diarrhea is very, very challenging. So based on the history, age, and the initial evaluation, the diagnosis can be narrowed down. So focused non-invasive investigation should be the first step in your evaluation, and then followed by invasive investigations if needed. And the management as well as the outcome will depend on the possible underlying cause. As I said, some of them will have a benign outcome, some of them will have a severe problematic and can even end up in death, right? and whole exome and genome sequencing are developing diagnostic modalities. Right.